Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today we welcome Bill Collins. He's a pediatric otolaryngologist. Today's Kevin MD article is Performing in a Clutch, Lessons from a Pediatric Airway Surgeon. Bill, welcome to the show.
Thank you, Kevin. I appreciate the opportunity to be on here and also appreciate everything you do to amplify the voices of those in healthcare. It's really valuable.
All right, let's start by briefly sharing your story and journey.
Certainly. So as you mentioned, my name is Bill Collins. I am a pediatric otolaryngologist, pediatric ENT surgeon by training. I have been here at the University of Florida in Gainesville, Florida since 2006, during which time I've been the division chief for pediatric otolaryngology. And over the last almost 3 years, I have also been the department chair for our Department of Otolaryngology here as well.
All right. And what led you to write this Kevin MD article, Performing in the Clutch, Lessons from a Pediatric Airway Surgeon? I could only imagine as a pediatric otolaryngologist, you have a lot of life and death decisions that have to be made or performed in seconds.
Yeah, a lot of what we do is elective outpatient things. And fortunately, I mean, knock on wood, the vast majority of the time things go well and they go smoothly. But every once in a while, we get those, thrown into unfortunate situations, particularly regarding the pediatric airway for myself. So really the genesis of this article was a few years back. We were doing a fairly difficult procedure. It was an exit procedure, an ex utero intrapartum procedure where we will plan those in babies if we anticipate that they're going to need ventilatory support right at birth and also anticipate there's going to be trouble getting an airway, difficult intubation. And I did this case with one of our residents and, it was a little tricky, a little dicey. Ultimately, things went well. It took a little while to get the airway, but since the baby was still, only partially delivered and attached to placental support, we had a little more time than usual to intubate the baby. And afterwards, the resident commented, he's like, that was awesome. It was so much fun. How did you stay so calm during that? And my first comment or first thought in my head was inside, I really wasn't that calm, as the clock is ticking. But it got me kind of thinking about this concept a little bit, because I know earlier in my career, I would have certainly felt that pressure a lot more, and that would have affected my, my performance. Some of it is also, I grew up playing sports. I have 3 boys. They've grown up playing sports. So watching them over the years and their teammates, how they react to pressure situations in their respective sports, it kind of got me thinking along these lines of, what makes a clutch player, and translating that into healthcare, certainly in our own field. How does a surgeon learn to perform better under pressure when they need it the most?
Now, before talking about some of those tips, what's it like to intubate a newborn? So take my audience into that situation. Just play out that scenario, because even as a physician myself, I can't even imagine that. So tell us what it's like to be in that scenario.
Yeah, I'll tell you, early in my career, my approach was a little bit different. And earlier, I had a lot of extraneous thoughts that would come through my head, and thinking about, oh, this is such a cute little baby, or, oh, the parents are going to be so mad at me if we can't, get this successful, procedure done. As I have evolved over the years, I've really become much more focused on the task at hand and taken a lot of that emotion out of it. So it has become, for better or for worse, a much more technical procedure for me by taking all the emotions out of it. And I really just focus on the task at hand. Do I have the right equipment? If we're talking about intubating, a baby who is desaturating, for instance, and, I'm not as focused on listening to that sat monitor drop. I know it's dropping. I got to fix it. So instead of focusing on the desaturation and that monitor that wakes us up in the middle of the night thinking about it, really focusing, do I have the right laryngoscope? Why am I not getting good exposure? Is the tongue in the way? Is the patient positioned properly? And sort of taking it very step by step, very technical, very analytical. And that has allowed me, I think, to handle those situations better and more effectively over time.
Now, you talk about that and other tips in your Kevin MD article, Performing in the Clutch, Lessons from a Pediatric Airway Surgeon. So tell us more tips and lessons that you've learned over your career.
Yeah, so in my mind, I think that there's two types of emergencies or pressure situations. There's the planned situations. You have a difficult case or a difficult patient that's scheduled for next week. You know what day it is. You know what time it's going to be. You can put preparation into it. And then there's the unplanned emergencies or pressure situations as well, which you can't plan for. For us, the dreaded phone call is there anyone from ENT in the room? Because they don't care who it is. They just need somebody to come help. So for me, I kind of break it down into what can I do ahead of time? What can I do in preparation before these moments, whether I know that moment is coming or whether it's not. And then I broke it down into what can I do when I'm in that moment? What is my mindset when I'm in that situation? Usually it's in the operating room, and the preparation part is, for us, we talk about sharing the airway. So planning ahead, communicating with the anesthesiologist or whoever you may be collaborating. It might be other surgeons. It might be a dual team approach. And spending that time ahead of the procedure before the situation, making sure you've got everything you need. Does everybody have all the equipment they need? Is it ready to go? Is it functioning? I look back a lot on previous cases that I've had. And for me, it just helps to take notes. I have binders full of notes from difficult cases and some, seemingly meaningless detail. What type of suture did I use, and what approach, what worked, what didn't, and it is important with all of these things to, sort of take note of what didn't work as well. So you don't keep repeating the same mistakes. Another big consideration is you just have to do these cases.
Yeah.
There's really no shortcut. Experience matters. And if you learn from your experience, that really advances you. And if you can help other people learn from your experience as well, I think it really advances the quality of care in your field.
One of the things that you mentioned earlier was removing emotion from pressure situations and looking at it more as a technical procedure. Now, of
Mhm.
course, that's easier said than done. So how does one go about doing that?
Mhm. For me, one of the biggest things, and it's a tough subject to talk about, was losing my fear of failure. And in medicine, failure is often death.
Mhm.
So, I had one particular case early in my career with a baby with a difficult airway that, things did not go well in the operating room. We lost the airway, and ultimately, the baby passed away in the OR on the OR table. And after that happened, that was always my biggest fear. And having that happen, and I learned from those mistakes and maybe some of the decisions I made, intraoperatively, I think that has really, the loss of that one patient has probably translated into saving, you know, 50 or 100 or more lives from the lessons I learned. So getting over that fear of failure allowed me to then, in those moments, really focus on the task and the patient and what I needed to do, and not worry. You have those emotional thoughts that are flooding your mind. What's going to happen? Am I going to get in trouble? Is this child going to die? Am I going to get sued? I mean, those are all things you can't be thinking about in the heat of the moment.
So, as you know, how people respond to pressure can come from who they are initially. And there's a spectrum of people who are innately able to deal with pressure. Now, you've been in academic medicine for a while now. Can
Mhm.
performing under pressure be taught, even for someone who is the most anxious coming in after training at a program? Can even the most anxious person can they be taught to perform under pressure?
I think that's a great question. That's the $1 million question. My current opinion is you can get better at it. I I do think some people are just wired differently in how they approach things, and you may self-select from one field of medicine or one specialty to another. If you don't like those type of situations, then perhaps being a trauma surgeon is not for you. But I do think you can get better at it. There are some studies that have looked at athletes and free throw percentage in the fourth quarter of basketball games, late inning batting averages, and And there's not a statistical answer for that. Even the best hitters, I mean, Michael Jordan missed a lot of game-winning shots. But I do think for certain people, if they are inclined to put themselves in a role that is going to face those situations, you can get better.
Now, you mentioned sports a few times, and as always, there is very few situations that are more pressure packed, of course, than some sports situations. And you have these athletes go to sports psychologists and use some techniques to help them perform under pressure. Are you seeing some of these techniques into medicine, perhaps seeing some type of psychologist or any other psychological techniques that you're seeing within medicine to help physicians perform in pressure packed situations?
I really haven't. I think one of the glaring deficiencies that I see in medicine is we don't get a lot of time to practice. And by practice, I mean training. Once you get out of residency and your fellowship and you're out taking care of patients, we don't get to spend a lot of time in simulators or learning, whether it's visualization techniques or meditation, whatever, those things might be, compared to, say, an astronaut or a military special operations, soldier, where they spend a lot of time in training. The vast majority of our training or our time is spent on the job, taking care of patients, with a very small portion in on the ongoing training. I hate to use the term CME because that implies, doing online training or something. But I think as physicians, there's so much financial pressure in the modern era, the corporatization of medicine, that we're not able to spend as much time with self-improvement and continued ongoing training as we get into our practice.
Now, do you specifically talk about managing pressure with your fellows and residents as you mentor and train them as they go through and rotate with you?
I do. And we always teach them, the anatomy and the physiology and the surgical technique. And I would say in the last 5 to 10 years, I've spent more time really trying to teach them about the mentality and the philosophy of being a surgeon and the different phases you go through over the course of your career, and the art of medicine and how you practice and how you deal with, in my particular case, it's more families and their patients. So it is something that I'm being more deliberate in talking about these concepts with our residents.
So, what's an example of that? So, what is the mindset or the philosophy of being a surgeon? What are some of the pieces of wisdom that you share with your residents?
Again, since I'm in a pediatric field, and a lot of what we do, is elective, and it's not life or death. So I talk a lot with our residents about shared decision making, for instance, in the office setting, if we're talking about, putting in ear tubes in a child or taking out their tonsils and adenoids, really, how do you explain that to the families and understand, the pros and the cons, the risks, the benefits, the alternatives? Because in many of these cases, it's a quality of life decision. And, to not come at it with a heavy hand and just, mandate that this kid should have surgery. What are the non-surgical options? What are the success rates? And really, it's a partnership with the families and these children and helping the residents understand that process.
We're talking to Bill Collins. He's a pediatric otolaryngologist. Today's KevinMD article is Performing in a Clutch, Lessons from a Pediatric Airway Surgeon. Bill, let's end with some take-home messages that you want to leave with the KevinMD audience.
Sure. 3 things come to mind. Number one, I mentioned this earlier, there's really no shortcuts. I think people turn to self-help books and some podcasts and different platforms, but you really just have to kind of get the experience and learn from it. Don't just go through the motions. So there really aren't, I hate to break the news, but there's not any shortcuts. I think it's also important to understand that, for a variety of physiologic reasons, nobody performs better, particularly with cognitive or very fine technical tasks. Nobody performs better in those situations when they're actually feeling the pressure. So the third thing is really the key is to separate your response from that stressor or that pressure situation, and learning to, create some distance there so that you may be in a pressure filled situation, but you are not feeling it yourself.
Bill, thank you so much for sharing your perspective and insight. And thanks again for coming on the show.
Appreciate it. Thank you, Kevin.